Good morning to all, respected moderators, sir. My heartfelt thanks to Sanjay Shubia, sir, and his team for inviting me to stand before you. Today, I am going to start with a very basic talk evolution of a stadium style. Myself, Dr. Vishwajit, I am from Guwahati. Any pathological respiratory sound in an infant needs immediate attention and should be carefully evaluated. All stadium children is due to laryngomalacia is a myth. Today's days of endoscopy with a bucket of other differential diagnoses which may also cause stutter. Noise diverging basically divided into stridor and strator. Stridor again may be inspiratory, biphasic and expiratory. Today I am not going to all this differential, all this diagnosis, but I try to create a roadmap for evaluation of all this pathology. If you go to history taking part, stridor most common association with respiratory distress, swallowing issue like cough and aspiration. He has also issues with a voice. His voice may be hoarse, breathy, and muffled. It is very important to rule out bronchopulmonary dysplasia, particularly in preterm baby, which is very major impact on this intervention. Also the cardiac anomaly and as a whole global development of the cells, as we have also evaluated in children with a hearing loss, there's neurodevelopmental issues. Again, respiratory distress divided into grade 1, grade 2, and grade 3, as you've shown in the diagrams, but it's more important when the cell is exhausted and we go for the endoscopic evaluation. We should keep all resuscitation ready. Quick history taking on stridor is the mnemonic specs, which deals with the severity of the symptoms, how the stridor is progressing, how his eating behavior like feeding and aspiration, failure to thrive, and also his any life-threatening efforts along with any history of cyanosis, also sleep disturbance. How is there any satisfaction during sleep, and also the aggravating and relieving factors like postural changes during sleep, stridor and exertion on older kids during running and playing, and during attacks of URTI, which generally this is found in bilateral vocal fold immobility. Yeah, endoscopy is the gold standard of evaluation of stridor. Prefer to do all endoscopy in endoscopy shoot where all this facility for bag and marks, proper oxygenation, because oxygen is a god, because oxygen will save the cell, and we keep neonatologists or interveners is always in endoscopy to keep standby. Though most of the evaluation, initial part of the evaluation is awake evaluation, dynamic evaluation. We also keep all these antidotes of Zylocan in our setup to deal all the crisis. Start with a flexible scopy. You see, this is where we can do flexible scopy. We can get kind of a two pathology, but maybe this is a one pathology where you have a secondary laryngomalacia. When you introduce the scope, we do vasoconstriction and go very comfortably. We don't jump to the other side. We go from one milestone to the other milestones, like the nasopharynx is the antidote, how his palate is moving, how lateral walls is any collapsing, any tonsillar hypertrophy, periepiglotic space, like that way, in a synchronized way, not in a haphazard way. In this diagram, I want to emphasize on, if you can appreciate, there is a bilateral cord mobility. So in that situation, we try to give some times during endoscopy, because some neonates or younger kids, they cries. When they cries, they are mostly in a adducted position. So it gives a false impression that he has a bilateral cord immobility. But if you give time, he starts taking bleeding, and that moment you can appreciate his abductory movement. So don't come out just a second, putting the scope and come out and have an impression of bilateral cord mobility. Similarly, we should go through lower airway also. Like this is a cleft. You can appreciate there is a cleft. Extension and cleft. Definitely, I'll go to the next presentation with a slide with how do direct laryngoscopy, but in flexible part we always do a complete bronchoscopy, so that we want to know any secondary air relations. Next, the rigid endoscopy. Rigid endoscopy is basically two types: direct laryngoscopy or a suspension laryngoscopy. We always try to care for the one bigger scope, like 5 mm scope, and 2.9 mm 36 is kind of a long scope. This is very important to negotiate. This scope is very helpful to negotiate when we have a grade 3 stenosis to go to the lower part of the extension. Very important to have a evaluation of exterior of his craniofacial look like a pre-veins macrocephaly. You may have a difficulty in laryngeal exposure. So this is our set. You may require 3 senior people for a 3-month child. The CMAC is very helpful. The mostly anesthesia people are using, and this is how we are doing a diagnostic evaluation with a high flow nasal cannula. This gives us less apnea time. So everyone is vigilant. Everyone is vigilant, and when you use inhalation, there is no drop of saturation. Pulse is maintained, and everyone is looking towards the monitor. And we kept all recordings for future evaluation. This is how it looks. We started actually the direct laryngoscope. My preference is always a straight laryngoscope, Macintosh laryngoscope, because it gives a direct view. And the Xylocon spray, we can also, without giving anesthesia, we can evaluate the side. But be careful, but maybe child may go to laryngospasm if we don't take proper care. This is how we can also evaluate spontaneously a child. This is the view, and this is how we can appreciate with a suspension. The cords are separated. We can go to the lower part of the cord, the subglottis. Laryngeal palpation, just I want to emphasize here, laryngeal palpation is not a haphazard way, it's a stepwise manner. We have to know why I am doing this palpation. Suppose movement of the cricoid nerve joints anteroposteriorly, medially. If it is intact, then normal cricoid nerve joint. If I try to push cricoid nerve joint laterally, introducing probe in interarachnoid space, if we are able to push the focal fold posterolaterally, then bilateral laryngeal palsy. It's unable to push posterolaterally, then this is the posteroglotic stenosis. So we have to differentiate in that way. Suppose this here in the video, if I push left side, then the whole glottis is moving towards left. So similarly, probing in case of cleft to get the maximum of the cleft, and also in case of congenital stenosis to rule out membranous or complete stenosis is very important. This is how we go for know the extension of the cleft. This is extension of the cleft. We also give some observation, like if you can appreciate any is there any laryngopharyngeal reflex, how is mucosa. It is a case of stenosis presenting with a stridor, then you can appreciate this mucosa is not well healed. There is acute inflammation, and if you give a time during the reversal of anesthesia, then you can get some information regarding the neurological status of the larynx. Can you appreciate here the fasciculation? The very veritable fasciculation you can appreciate in this video. So that means this neuronal connectivity is intact. Okay, this is going to be my last part of my presentation. Grading of airway stenosis. We know the subglottic stenosis, tracheal stenosis, laryngotical stenosis present with a stridor. When you've got a stridor and we have found a stenosis, it is not the, we have found most of the Mayer-Kotter grading is a component of every slide of airway surgeons, but it is not the subjective grading. It is not the visual endoscopy grading. If you see, this is, suppose this is grade 1, this is grade 2, grade 3. But why it is grade 2? Why it is grade 3? Why not this is a grade 3? Okay, this is grade 4. So it is not kind of a handoscopic view, or it's a measurement by centimeter. You can appreciate in a scale. So let's take this example of this child. It is a 6-year child with a recurrent hospital admission for group with respiratory distress and stridor for last 6 months. He is in and out, and with nebulization stridor still persist. Then when we do flexible scopy, then we have found that he is also not almost kind of a normal airway. The dynamic airway, the supraglottic is normal almost. Both 12 folds are mobile. Then whole lower airway is also normal. No growth, nothing else there. Then we did a rigidistoscopy and a deep cephalopolar implant. Then we have found that he has almost normal airway, mild dynamic collapse. Then we started measuring his stenosis, but never start without a muscle relaxation. This is a key here. We always paralyze the child. Don't try to intubate the child without using muscle paralyzing agent. For this 6-year size, ideally it should go 4.5. So we start with a 4.5 endotracheal tube. But you can appreciate that after proper relaxation also, this 4.5 tube is not able to intubate. Then we go with 3.54, then come down to 3.5. But at 3.5,
there is no leak. There is not
3.5 there is no leak. That means how do you leak this? By difference of inspiratory and expiratory volume. And in endoscopy, we can observe there should be a leak. Then we went to a 3-size tube. So we can appreciate that there is a leak. So this 6. So
3-size 3.5 leak nasile na
3.5
no, it did not.
So yato dekhaise na Daisy.
Some coming out now.
This air bubbles is coming out. So this bubbles. So let's do some mathematics. So this is 6-year child. As appropriate tube is 4.5, should be 4.5. That's 4.5 should tubes go. Leak test is positive as 3. So 6-year size, leak test is positive. Then it is a grade 3 subglottic. This is a chart we use for do this mathematics. So radiology always a sometimes complementary. We can do virtual bronchoscopy to rule out any SOL, but you need the sedation, you need the intensivist during the endoscopy to some need sedate child. But very beautiful way to evaluate any focal cord and focus, I think, is the most useful tools for airway evaluation. Okay, this is the last case scenario. You can appreciate is a 1 month 10 days old baby when I introduce the 2.5 endoscope. Then and we have coming down in a very slow motions. Then we have found here is a circumference narrowing. So it is not that due to his intubation it is quite low, just above the carina. We can appreciate the rings. It's quite low, and you can see it's a kind of posteriorly also. It's not flat. It is not flat. It's circular. So it's a complete tracheal. Then when you evaluate, then we have found this. So this way we can correlate radiology and endoscopy. But very important that here the cartilage is not developed, so you can appreciate the tracheal cartilage, but you can definitely use the soft tissue component with a bronchoscopy. So that's how we can correlate. So the last point of my today's presentation, if you see if these things is happen during the endoscopy, then what will you do? There is a severe laryngospasm. It's not by Beg marks. There is a bradycardia SpO2 fall. And what Beg marks cause, this is a very beautiful diagram. So the effect of back pressure on the closed larynx, attempted initiation of lungs, distend the piriform fossa and reinforces that closer. So vegan mass is not indicated in this kind of scenario. So ultimately, that's why in intensivist anesthesiologists are preferable to do in endoscopy room or neonates or younger kids, because children's, all children, to if these things happens, because and also require a IV cannulation, because ultimately it will relieve by um, muscle relaxants only, introducing muscle relaxants. But this is a very beautiful paper. If it happens accidentally or an unplanned way, then this is a one maneuver which you can do, like chest compression to relief of the laryngospasm. Just gentle chest compression. Thank you so much. Thank you, sir.